Good evening, everyone. It is Tuesday, the 9th of June. My name is John Draw. I am your digital producer here for our COVID cast, which according to the slide on screen, we are in our 12th week of doing our weekly COVID-19 town hall broadcast with Dr. Sanjay Udoshi. It looks a little different this week. I'm broadcasting from Sword in the Stone Games in downtown Wilkes-Barre, where I work, and we have reopened and have sanitized everything every hour, and everybody on that side of the room is wearing masks, and it's a crazy time, but here we are. Good evening, Sanjay. How are you?
Good evening, John. Good to see you. So, hi everyone. Sanjay Udoshi here. As John said, this is we're welcoming you to our 12th weekly town hall. We have adopted a webinar format in order to accommodate and better manage the questions that will be coming at us, as well as we have we've recruited Karen Kirsch from Wisconsin to be a moderator. And as usual, we have Terry Munt from Texas, who will be our lead troublemaker tonight, as he has been for many, many weeks at our side here. So we're very happy to have everyone. Today we're going to cover a few topics and then really go back to the conversational format that we do very well with. Last week, for those of you who are rejoining us, we had Dr. J.J. Racimus, and we focused on psychosocial aspects of COVID and what it has done to the care of patients in psychiatric and other settings, both in hospital and outside. What it means to social work. Dr. Anna Perez had joined us and talked to us about what it means in the social work professional arena. And it was a very insightful, wonderful time with them, and I'm thankful again that they were able to join us. Today we're just going to be talking about some of the more, some of the topics that have come up in the news in the last week and that may be of interest and may stimulate some questions and conversations. So what we are going to do is start with our slide deck, if we could bring that up, and we'll just go over the topics quickly, and then we'll open it back up. John, are you bringing the, there we go. So, a lot of questions have been coming at me recently in the last few days about reporting, the rocky relationship that the United States has right now with the World Health Organization, as well as what does that mean for our COVID response, and what does it mean to isolate the United States from the response to COVID that is being coordinated by the World Health Organization throughout the rest of the world. Also, reporting and numbers and standardization is something that we talked about two weeks ago, and in the lack of a national standard in terms of the definitions of who is presumptively positive, who is a confirmed positive, and then of course through the disease progression to outcomes, and whether the outcome is a full recovery, whether the outcome is with a morbidity, and how long is that period of time necessary for us to be evaluating these patients after they've recovered. And then again, the numbers that have been of growing attention over the past months. The case fatality rate, how does the United States compare to the rest of the world, and whether our response to the treatment of these patients has been adequate, and whether that has changed over time. All of these questions are being discussed, not only directly to me from people who are interested in understanding it better, but also within the biomedical community, trying to understand how to do better reporting, standardization, data analysis, and things like that. And then, of course, the questions around which recommendations are valid, which recommendations should we follow to stay safe. John mentioned that a friend of his who works in a warehouse environment had started off in the February-March time period being told masks are not necessary. The Surgeon General said masks are not useful, and then being told to wear a mask, and then not being provided one by the workplace, and then eventually the workplace making it mandatory, and then all of these recommendations that have changed over time. Even people asking me, Dr. Fauci said that in the early going in January, early February, that COVID did not present a very high risk to the United States, and here we are 5 months later with over 100,000 people who have passed away as a result of the infection, and we're approaching 2 million cases here in the United States. Almost a third of all cases in the world are here in the U.S. So, who's right, who's wrong, and who do we believe and who should we trust, and all of those other aspects. We'll cover those. What else is on that list here? Sorry, John. Okay, so next is the asymptomatic spread. Over the last 2 days, 48 hours, a World Health Organization representative physician said that the asymptomatic spread of SARS-CoV-2 is rare. That has been taken back now, and they've walked back that statement. It was some would say poorly phrased or whatever. I just think it was kind of irresponsible. So first of all, if any organization is to release a statement, there should be a significant amount of debate over the wording, and especially coming from clinicians and leaders in epidemiology and spokespeople for organizations like the CDC, Health and Human Services, and even on the world stage, the World Health Organization. Words like rare have to be qualified. Asymptomatic has to be well defined. And we're going to cover a little bit of what those mean and why we should not pay attention to that very close. We should not take that recommendation as being valid. We're going to cover a little bit about, unfortunately, I didn't want to do this, but I have to, disinfectant misuse. The CDC has released new guidance based on a survey that they conducted after the statement was made regarding the use of disinfectants, at first by the director of the BARDA lab, and then, of course, the misinterpretation of that by the president. And so we'll be covering disinfectant misuse. Also within that category, we're going to cover, again, when is the best time to use a mask, and when do you use gloves, and when do you not use those things now going forward. We're going to cover a little bit about the vaccines that are in development, because they're increasingly becoming part of the news cycle, with various teams across the world releasing information about what phase of clinical trials they're at, and whether or not that particular phase has been successful or useful so far. Something that John and I brought forward about 5 weeks ago is the realization that COVID is not just a disease of the lungs. It is definitely a multisystemic disease. It causes pneumonia and very high fever in the majority of cases, but it also causes clotting, and it also causes what we call a hyperimmune response, or an autoimmune response, which the body begins to produce an autoimmune destructive response. And so really we've begun to realize that the real killer isn't necessarily just the pneumonia, but it is the other aspects of the disease. And then we'll talk a little bit about what is your new normal? What in the states that you live in? How does it compare to, let's say, the third or fourth week of January? And what does the third or fourth week of June look like for you? Or what will it look like for you? So, okay. So then the next slide here, we're covering, we always cover the numbers initially. The numbers, I forgot to label those, but if you see now the United States has crossed 2 billion positive cases of COVID. We have just dropped below 20,000 new cases a day, which is a very, very big number. And actually, you'll see at the bottom right chart that the slope of the line of decreasing cases continues to move slowly towards us seeing less and less cases, and we've finally fallen below 20,000 new cases a day. We are still seeing significant amount of deaths every day, over 500. This is down from almost 3,000 a day that we were seeing about 4 or 5 weeks ago. Actually, yeah, 5 or 6 weeks ago. We're now being followed by Brazil, Russia, Spain, United Kingdom, India, and Italy as those countries having the highest number of positive cases. On the upper right here, you'll see the curve of cases, which is the rising death count. Okay, this is specific to the United States, but unfortunately, the red line didn't come out very clear. If you see the initial 4 weeks of the response, the slope of the line is very steep, and now in the latest 4 weeks, the slope of the line has changed dramatically. So that represents the rate of mortality or the rate of deaths over that time period. So the rate of death has fallen significantly from the beginning of the response now to the latter part of the response, which indicates that our treatment modalities and our treatment of these patients in the worst cases is improving. So less people are dying of the most severe course of disease. Next slide. So here's a complex slide. I'm going to start at the left side here. Finally, in the outline, the blue outlined county in the middle of the screen, which is Luzerne County, where John and I reside, which has been a hotspot in Pennsylvania from almost the very beginning of the lockdown. We have finally seen the first day without any positive new cases. So that has represented a 3-week continuous decline in the reports of positive cases. That's excellent news. We see a slower decline in overall positive cases in the state of Pennsylvania from a height of almost 1,100 in that one day, all reducing down to now 431 new cases in the rest of the state. And luckily, our county has seen its first day without a new case. You'll see in the gray box some facts that are being now distributed by Johns Hopkins with for each county. So some of the things to note in our county are, the number of ICU beds is 74. The number of fully staffed beds is almost 1,000. The ratio of ICU to fully staffed beds changes county to county. And so in the counties that are hotspots, moving equipment and personnel to those hotspots, we learned a lot about how to do that effectively in Pennsylvania. And a lot of what goes on at the Department of Health level in each state is unseen by the public. So this is John and I tipping our hat to Dr. Levine, her staff, and the people have worked very closely with the private healthcare systems throughout the state to make sure that they had whatever they needed to address the burden. So within our county, you see that we're a highly majority white county with smaller minorities. of about, a total population of 300,000. You'll see that on the middle race graph there. Ethnicity, mostly non-Hispanic, with a small Hispanic population in the middle of our county, in a locality called Hazleton. And then you'll see that our largest age group is between 35 and 64, but we do have a significant number of patients over the age of 75. And this is going to be important in the next slide, because we have now begun to realize how horrible a disease this is and what a toll it exacts on the elderly. So one of the things that you'll see the counties in northeastern Pennsylvania listed here: Carbon, Lackawanna, Lehigh, Luzerne. We're in Luzerne County. Our bordering county is Lackawanna. We have turned yellow, and the other counties you'll see that are more sparsely populated have turned green, and that means different things for us. That means, certain businesses can allow dine-in in the green, but we're still not allowed to dine in the yellow. So that's our status report for northeastern Pennsylvania. John, you want to add anything? Mute.
Using a new computer, and it is a little different.
Okay.
I think that it's an interesting environment. Sanjay has said a couple of times during the last few weeks, the people that live in Shavertown, where Sanjay lives, which is a second-tier suburb of Wilkes-Barre, to the people that live where I live in Kingston, which is a first-tier suburb of Wilkes-Barre, tend to be following the guidelines and behaving, for lack of a better term. When you get into the cities itself,
there's less compliance.
We see less compliance. We might as well address the fact that obviously there are protests that are happening in communities all over the country this week and the last 2 weeks. And I think that one of the challenges with people in general is, we have short attention spans, and we as a rule listen to whoever yells loudest, gets the attention. And I think a lot of that has taken some of the focus off of the pandemic. And I think that, if people take a step back and really look at the socioeconomic and racial disparities that are happening across our country, and bring into the picture healthcare, and bring into the picture access to healthcare, and individualized and community treatment options for health issues, you see a very different picture in communities of color. So I think that that's worth mentioning, and I think that we see that here. Luckily, we have some friends that are involved in these protests and rallies, and have been able to, get the word out there that, hey, yeah, you should be wearing a mask. You should be keeping socially distant. If that becomes not possible. So wearing a mask should never become not possible. But if social distancing becomes not possible, there are disinfecting things that you should be doing. And I know Sanjay is going to cover that in a little bit. But I think that that's something that's happening. And I heard a story, an NPR story the other day, that there are these protests and rallies happening in the smallest communities in our country. And the reporter had said, think of the village or the township or town nearest to you that you think that's so small, there's not going to be a protest there, and you will find a gathering there. So in a time where we're being told and we're advising, don't go out and stay home, and don't go out, and certainly don't go out in crowds of more than 12 or 18 or 25 or now 50 people. You know, people are just motivated to go out to rallies where there are hundreds and 250 and 500 and 1,000 people. Um,
Yeah.
and you like to think that they know what they're doing, and you'd like to think that they have thought through the risk involved. And if they are a low risk person, maybe they're balancing that. You like to hope that someone's saying, I'm healthy, I have no pre-existing conditions, I'm 30 years old, and healthy as an ox, and I can go out and be fine. I don't think that's necessarily what's going through people's minds right now. So
yeah.
Anyway,
yeah, no, I
that's
totally
my feedback.
I totally agree with what you see, what you have seen, and what you're saying. We live in a pretty small community in the Wilkes-Barre, Scranton area, and we had 2 large protests here. I mean, large for us is hundreds of people, and that's exactly what we saw, hundreds of people. And then in Philadelphia, you had tens of thousands of people. So and that's not far, and we have a lot of commerce and transit back and forth between northeastern Pennsylvania and Philadelphia. So will we see some spikes from? Yes, we will. Just like I said, we would see spikes from those who were protesting the lockdowns, and we did. And so our hope is that it's not going to be, very big, devastating spikes that, lead to some return of this curve. But like John said, and we've actually, I've seen some physicians putting videos out saying, okay, if you're going to go out and protest, this is how we want you to go out and protest. And, like to John's point, not everybody's going to see those videos. Not everybody's going to, in the heat of the moment, do the right things all the time when they're out there. And then if you're, what I was really disturbed by was if you're confronted by law enforcement and they start using, pepper spray or tear gas, what's the first thing that causes? Massive mucosal unload, right? Sneezing, coughing, throwing up, eyes watering. I mean, then you have a crowd full of people doing that, and maybe some of them are asymptomatic carriers. They're now becoming super spreaders in that crowd. So it's not safe to go out and protest. I said this last week. People are seizing the moment. They're moving. I mean, they're going out there, being moved by emotion and by passionate to say that what they are seeing in this country is not acceptable. It's not right. It's and so they do that, but they also put themselves at significant risk in doing so. So let's just be very clear about that. And we also talked about how it's I think it was in the post show last week about this is the 15 minutes of fame for this issue. Once the media gets bored of this, there's not going to be coverage of protests until the next person is egregiously murdered. And this is how our media deals with our issues in this country. This is what we saw throughout all of last year with gun violence and mass shootings, right? It was an issue for 5 days post some horrible event, and then it goes away. Well, one thing, tying it back to this town hall is COVID is with us to stay. It is here for at least the next 18 months as a threat to the population, to the entire United States as a society. And there's plenty to protest about what's not right in this country. But we should be aware that we have to do it safely, and guide those that wish to do it, arm them with the right information to try and be as safe as possible, is all I can say. Okay. Terry, did you have something? I saw you lift a finger.
Yeah, I did. I just, from seeing photos of numerous protests, there are masks being worn.
Mm-hmm.
There is effort being made there.
I do.
Of course, with the crowds, you can only always be 6 feet apart. I have seen smaller protests where they did, an extraordinary job keeping apart from each other. But those are the smaller ones. Anything over a couple hundred people that gets thrown out the window.
Yeah. Yeah.
So Sanjay, just to synthesize, you are pro-test, but
Yeah.
not pro-protest.
I am. Exactly. If we can't be silent, and at the same time, it's a horrible time to be putting yourself or everyone else at risk. So what can I say? I can't ask people not to express themselves.
So if someone does go to the protests,
Mm-hmm.
what would you recommend as to how long they should wait to go get tested? In my area, we have now moved to a stage of you can get tested no matter what, if you have
Yes.
symptoms or you don't have symptoms, and it's free,
Yep.
which is great. But how many days would you say that people should wait before they go check themselves out?
I would say 36. Well, no, I would say to be safe and to make sure that the test will effectively find an adequate sample if you are indeed infected. I would say on the 4th day after exposure.
Okay.
Some doctors are recommending as early as 36 hours. So that would be, day 2. But,
And then once they have that test, are they in the clear from that incident? Should they go back another week later, or is that good if they get a negative test back?
That's an excellent question. So I would say that the best thing for them to do is if they are in the clear on the 4th day, and then they're asymptomatic for the next 10 days, they're pretty much in the clear. If they start developing symptoms, obviously, then that means that test was too early and the test didn't pick up the illness, and they should get tested if they start feeling ill. Now, just to go get tested 14 days after you've already had one test, it's up to you. But on the 4th day after exposure, you should definitely go get tested. And then the more important thing is, what if it comes back positive? Then you have to do your 14-day self-quarantine. You do have to separate yourself from friends and family and not go out in public. That's strict. That's a strict recommendation. Okay.
Okay, great.
Next slide. Okay, so here is some very, very disturbing information. The percentage of deaths per state that occurred in long-term care facilities, and a long-term care facility is defined as any skilled nursing facility, personal care home, assisted living residence, community residential rehab service, or long-term structured residence. So basically where old people live, okay? So where old people live in Minnesota, 81% of all fatalities occurred in these long-term care facilities. New York, where you had a hot spot and was the hardest hit metropolitan of all in the United States, had only 20% of their reported COVID deaths in these long-term care facilities. And then obviously you see a spread between the various states. But by percentage, an incredibly high percentage of deaths occurred in the states Minnesota. I would say, Connecticut is abnormally high. 70% of deaths, about 2,200 elderly died in long-term care facilities in Connecticut. Pennsylvania is also extremely high. 61% of all the deaths in the state from COVID occurred in these long-term care facilities. So that's 2,807 persons lost to the disease in one of these facilities. So now we have, some mobilization of attention towards these facilities. And in the most recent briefing, our Department of Health here in Pennsylvania has issued strict guidance to these facilities on testing and on protecting their populations. So like I said 3 or 4 weeks ago, the lack of a standardization of the protocols in terms of how to address testing, how to address the staff testing, and provide, an absolute quarantine of these patients has resulted in this failure. This is horrific. So, and again, let's look at New Jersey. 51% of deaths, over 5,500 elderly died in long-term care facilities in New Jersey and also in Illinois. So obviously those near major urban centers were affected heavily.
Minnesota at the top.
Yeah.
What's going on in Minnesota? Is Minnesota the new Florida?
I don't know, but it's just pretty horrible. Like they must have had some sort of testing failure for the staffers of these facilities. So these staffers were acquiring this at home, coming into their facilities, and then infecting everyone repetitively over a long period of time, over let's say 2 months, So now we have universal testing in nursing homes in Pennsylvania. This to me has come 3 months too late. And this is what happens when you allow states to do their own thing without a national standard. And these people have paid the price for it, and their families. It's pretty bad.
Sanjay?
Yes.
Yeah, my mom was in an assisted living home in Illinois when she passed back in March. It's closed now for the number of deaths that happened, and 3 other assisted living facilities she was in, not that she was in, but in the same town, were closed also, just for the high number of deaths and infected inside of them.
Yeah.
So Sanjay, for the elderly, is it just that their immune system is slower to get going, or what is kind of the mechanism?
So I discussed this with Dr. Nuthi, and he said that my theory was all of the systems at the age of 75 plus undergo something called senescence, right? They aren't able to they're not able to repair themselves as quickly as they are in the younger age groups, especially under 65. So if you talk to any elderly person, it takes me 2 months to get over a cold. It's just that their systems have slowed down in terms of the repair and recovery. But there's also a theory that Dr. Nuthi made me aware of, that in the elderly, it isn't necessarily that their ramp up is slow for their immune system, it's mistargeted. So they are the ones most likely to suffer the clotting and the inflammatory syndromes that accompany very poor course of disease with COVID. So that's one of the reasons that we're seeing that it's so much more fatal for those over the age of 75. Yeah. So it isn't a slow ramp up compared to the other age groups, because the ramp up is about the same period of time that the T cells get involved, and then they stimulate the antibody production, but it's just mistargeted. and then they end up with very poor prognosis. Okay, next slide. Okay, so a question came to me. Let me just see the participant list here. A question came to me from Gregory, and I sent him this chart. And one of the things that I want to cover is about asymptomatic carriers. Asymptomatic carriers are the ones that are walking around in the protests not knowing that they're carrying the virus. They don't feel sick. And there is data to show that of the patients that are exposed to an adequate quantity of infectious agent, and whatever that quantity is, we have yet to determine. But if you take 100 people and you all expose them to the exact amount of droplets, each of them, okay, and in those droplets is the SARS-CoV virus in the adequate amount of viral titer. So across those 100 people, 40% of them will carry the virus without showing any symptoms, and they may actually never show us symptoms. And then the remaining 60% will have the course of disease. And again, I say this every week. You take that 60%, those 60 people, of those 60 people, 80% of them will have a bad flu or a mild flu, and they'll recover fine. 10 to 12% of them will have a pretty severe course of disease, but they may not require or seek hospitalization. So they may be sick for 2 to 3 weeks, and their recovery is slow, and they have very high fever for 8 to 12 days, and they may come away with what we call morbidity or sequelae. So they feel not 100% even after they recover. Then there's the 8% that will require hospitalization, and within that 8%, there's about 1.5% that will die. So this is how this breaks down, okay? And this is what we're seeing, across the board, no matter what country you live in. However, the case fatality rates are different. That may be attributable to the way they were treated. In fact, whether they received the correct modalities of treatment, whether they arrived at the hospital in time, and all of those other factors. But that contributes to case fatality, but the disease itself, the mortality rate is about 1.5%. Okay, so what is asymptomatic carrier? All right, so you get exposed, and so from the time of exposure to about 7 days average is when the onset of symptoms occurs. It can occur, the onset of symptoms can occur as soon as 2 days after exposure, or as long as 14 days after exposure. So we kind of average it out to about 7 days. And that's when there is the rising titer or viral load. And during that rising viral load, there is shedding. Okay, so the virus is actively reproducing in the endothelial cells of the mucous membranes, epithelial cells of the mucous membranes, and then it is lysing the cell. It's causing that dry cough and irritation and all this other stuff in the symptomatic patients. But in the asymptomatics, it's doing so at a much lower, what we call subclinical rate, and then it is shedding. And so it will do its shedding, and if it finds a more favorable host, then it will become more virulent than that host. But for those 40% that never show symptoms, it may just kind of use you as a life raft to the next case where it can be more damaging or more virulent. How and why it does this is still being investigated, but this is what it comes down to. So that first week of the post-exposure is when you have asymptomatic carry. And then it could last up to about a week after. So, could the carrier have the ability to spread this for up to 14 days? Yes, we think so. Okay. So you can see that reddish orange line, virus isolation from respiratory tract. That means that underneath that line, John, if you could highlight it, underneath that orange line is where you're seeing the potential spread of the virus. Okay, so that's that. And then the two things that are being what we're trying to test for, obviously, is in this initial period of the 1 week post exposure. And Karen just asked the question, how soon after being out at the protest should I go check if I have, contracted the virus? 2 days might be too early, right? If you could look at that at the point in time where the blue line is not, it's not very detectable at day 2, right? But about day 4, which is midweek, you can see it getting very high in the viral titer there. There you go, John. Okay, so that's when you want to get tested, because then you're most likely to get that positive if you are positive. You're less likely to get that positive if you're carrying it on day 2, and that curve explains that. Any questions? Okay. All right, so the two things that we're testing for are seen on the right. On the top right here, you see the RNA. RNA is single-stranded nucleic acid. That is the genetic material of this particular virus. Some viruses have the double-stranded version. Some viruses are DNA viruses, but COVID is an RNA virus. So the test that we look for, this detection test, is looking for RNA. So we put the swab up in the nasopharynx, and it gathers the cells and the other detritus from there, and you put it in a tube and you clean it out so that the only thing left is RNA, and we have various techniques to do that. And then you put it in a machine, and the machine amplifies it, makes millions of copies of that specific RNA if it's present. If it's not present, then it won't show up. And this is the detection test. And then the antibody test, John, if you could highlight the IgG, so it's the green one. It's the green dotted line. So the green dotted line is, that one is the line that is showing that you were infected by the virus, and your body then was stimulated to produce antibodies for long-term immunity. In this case, long-term immunity means about 2 to 3 years in this particular class of viruses. Other viruses, we could have lifelong immunity, like mumps and measles and things like that. But there are different reasons. We don't need to go into that. For this virus, if you've been infected, you can expect about 2 to 3 years immunity from this particular strain. It may mutate in the future, and then the immunity that you have right now really is only for this year's version of it. And then you would have to, receive a vaccination in 2 years to continue to have the appropriate protective antibodies. Any questions? All right, next. Okay, so we already covered this. Basically the World Health Organization has walked back their statement. Dr. Kirkove, basically said that it still seems rare, the asymptomatic spread, but that makes no sense, both from an epidemiological perspective and also from a virology perspective. So on the chart on the bottom is a simplified version of the one that we just showed you. There's an asymptomatic stage. There's a, the window period of when we're detecting the virus via RNA test. And then within 14 days, the Ig immunoglobulins start to peak. And then we start to get the IgG, or long-term protection, is the red line. And that will remain in the blood and provides the long-term immunity. Okay, so that's kind of a simplified diagram. So this is the various times where it's detectable, and the statement was dumb, and we'll leave it at that. There we go.
Hey, Sanjay.
Yeah.
Sorry to interrupt you. I've read a couple of different times, and the problem we're having with everyone mass consumption of all this different info coming in.
Yeah.
Is I've read that people who are asymptomatic might not be having the long-term benefits of antibodies to this particular, and it's like, it's a barrage constantly of 100,000 different sources telling you all different things?
That's an excellent question and an excellent point. And it is indeed, we believe, and it has yet to be confirmed, but I've had significant conversation with Dr. Nuthi and other people in the in hardcore immunology community. They believe that that is very much going to be discovered, that those who are asymptomatic carriers will not have the long-term immunity. They, what the innate immunity that fought off the virus did not stimulate their B cells. It was like, they didn't, the ground troops never called the colonels and the generals to tell them there was an invasion. They just took care of it themselves. So there was never any memory of this infection. It was just something that happens every day to all of us. We're covered in bacteria, we're covered in viruses, and they don't make us sick. Okay, we just take care of it with our innate immunity, the stuff that protects us normally in our mucous membranes and things like that. But that doesn't confer that what we call adaptive immunity. Okay, so those carriers will not have antibodies, like you said. That is probably going to be discovered and elucidated by some science in the next 6 months. That like I said, 40% of people exposed to the virus carry it, never get sick. Innate immunity takes care of it. 60% actually progress down the disease state. And those 40% that walked around with it for 7 to 10 days or 14 days were the ones spreading it most significantly versus the ones that got sick and stayed home or whatever. So that's probably what we're going to find out. And as far as the information that's coming out, I'm glad you raised that point. It is indeed, some of them may have what we call subclinical infection. So I had a dry cough for 2 weeks. I had a dry cough, like Michael, no, my classmate, and you as well said that you suffered some sort of illness that was unusual early in the year. And then it actually might be that you did have a subclinical infection. It might have been COVID, but when you go to get your antibodies tested, they come back negative. And that happened for you and Michael. So that's a great question. Yep.
Well, I did have a bad test, so.
When you said Dr. Kurt Covey, I thought you said Kurt Cobain. That's file that under misheard lyrics. Dr. Kurt Cobain. Am I the only one who heard that? Let me know in the chat. That's probably just me.
Are the antibody tests more accurate now? I just printed a paper on that. There's two answers to that question. So we're beginning to see that the antibody tests were not necessarily inaccurate, but they were unreliable. What does that mean? That means that that they were specific for the virus, right? They were looking for the virus, antibodies that were created by your body against the virus, and they were pretty specific to that. But like we just covered, we don't know how many patients have gotten ill and then that illness never elicited the adaptive immunity or the humoral response. So they are accurate for those people who definitely had a humoral response, an adaptive immune response to the disease. Okay, but then we have to take a step back and say, well, how many people definitively had an immune response? Is it that 60-40 split? Is it a 30-70 split? Are some people getting better without getting their T cells and B cells involved? We may discover that is the reason some of those tests are giving us negative results, even though the patient was a carrier, even though the patient did get sick. So that is problematic. Okay. All right, next slide.
All right, before we jump into that, I want to remind everybody that we are using the Q&A feature tonight. So if you have a question, you can use the Q&A button at the bottom of your screen to submit a question, and we will make sure we get it answered. There we go.
Okay, so the CDC, for reasons that are somewhat obvious, had to do a survey, and they got 500 respondents to answer an internet survey, and this is what they discovered: about 65% of people who of the respondents did report that they increased their frequency of home cleaning. Okay, that's great news. So they are definitely disinfecting surfaces and doorknobs and things like that. That was part of the questions. And so that's great news. Bad news is a lot of them are using high-risk practices, even up to about 20% of these people who responded, that's 100 people out of that group, said that they've been using dilute bleach to wash their vegetables and fruits. What's the dilution ratio? What's the residual chlorine on these? Is that acceptable to ingest? No. So are they using household cleaners to disinfect their hands? Again, you don't want to use caustic or corrosive chemicals on your bare hands. That's terrible. Did you mist their body, like coming back from somewhere with a cleaning spray or alcohol, spraying themselves down with Lysol? Up to 12% of the respondents said that they did. That's terrible. They inhaled a vapor of household cleaners like bleach, or drank or gargled a household cleaner, or dilute bleach solution. Guys, please, please don't do this. And then a significant number said, no, we didn't do any of this. We haven't changed our behavior at all, which is also dangerous. So not a lot of great news here, other than about 60% or more definitely are cleaning their homes more thoroughly. 20% said, no, I haven't changed a thing about my behavior. Okay. That's in line with what we know about our society, I think. And then among those that are using high risk practices, those were the answers that were the most concerning. Okay. So does anyone have questions here? Because this is, obviously important information to tell your friends, your family, that they should not be doing. Okay. They should not be washing fruits, vegetables, or anything else with any disinfectant or cleaner. They should not be using caustic or corrosive substances on their bare skin, face, hands, or body anywhere. They should not mist themselves with things like Dettol or Lysol. Do not inhale the vapors of any cleaning products. Don't use household cleaners as a mouthwash or gargle, or soapy water for that matter. None of these are protective. And then obviously, bleach should not be used on anything other than a surface or clothing. Any questions?
Cynthia just wants to confirm that this is for real, Sanjay, and I could see her doubts.
100% correct, real. CDC data. Yeah.
Wait, hold on. This is the slide I'm supposed to do this on. But Sanjay, what about gloves?
Beautiful, John. It's almost as if that was so spontaneous. Amazing. Okay. So yes. So Karen, my wife, works at a dental practice and has seen a lot of patients come in. They have obviously given them information before they come in recent days about social distancing, a preference for them to wait in their car rather than in the waiting room, and things like that, just to protect the practice and protect the patients within the practice. And a number of patients are coming wearing gloves. And one of the things I want to make very clear is, please don't wear gloves in public. There are two reasons. One is And I talked about why you could potentially wear gloves if you're grocery shopping and how to use those. So I'll cover that. But in general, do not drive with gloves on. Do not walk around in public with gloves on. The use of gloves by the public is pretty much, well, I'll use the word contraindicated. It's unnecessary, and it could actually be something that ends up being more harmful than good. So she had a patient come in, and one of the problems with gloves is that whatever nurses and doctors use gloves to prevent cross contamination. So I'm dealing with a patient. I have to do a procedure on a patient, and then I immediately have to go to another patient. What we do is we glove, and then we remove the gloves and discard them, and then we use new gloves on the new patient. And if we have time in between, then obviously we'll do the whole hand washing and scrubbing. But when you're dealing with a number of patients, let's say you're in an outpatient setting and the doctor has to see 25 patients in an afternoon, and you're in a high-risk circumstance like in the middle of an epidemic or pandemic, the glove is to prevent cross-contamination. So any surface to person, any person to surface, any person to person, this is what we call, cross-contamination. Now, to prevent that, the glove is a very temporary barrier, and that's crucial. If you wear the gloves out in public and are going from store to store wearing the gloves, or going from location to location, you're basically dragging around contaminants on those gloves. Okay, but then you'll ask, Sanjay, well, don't you do that with your hands? Well, that's why we're asking you to follow hand hygiene. Okay, so if you leave a store, you should have a hand sanitizer and use that, temporary 70% minimum alcohol hand sanitizer, and use that after you've left a location that there's a high human traffic. And then, so when you go to the next location, you're not potentially dragging those contaminants to the next location. It's simpler to use the hand sanitizer than to remember whether you have actually contaminated your gloves. And so we just ask that, if you have a task list of, I need to go to the bank, and then I need to do the grocery store, and then I need to do this, and then I need to do that, taking gloves and using them throughout all of those locations is just not a good thing. Okay. And then what you potentially could do is jump in your car with those gloves that but Sanjay, I would have done that with my hands anyway. Yes, but that's why we're trying to promote the habit of hand washing and hand hygiene, not the habit of wearing gloves. I hope that is clear. Okay. So cross-contamination, go ahead.
Oh, we do have a question from Madeline, just going back to washing fruits and vegetables. She uses, or someone she knows uses, a hydrogen peroxide type of a spray. Is that safe? I personally use a vinegar mixture.
Yeah, it's hydrogen peroxide is largely safe, but unnecessary. Okay. One of the things that with fruits and vegetables, there's very little evidence that on surfaces like metal and plastic, non-porous surfaces, the virus doesn't do well. Okay, so it hardly lasts 3 to 6 hours. On organic surfaces like vegetables and fruits and other things, there's actually quite a bit of competition going on there. There's all kinds of other microbes that are going to scavenge protein, fat, all this other stuff. They all are, there's this whole hidden world on your fruits and vegetables that are taken care of well by cooking it, or if it's a fruit, obviously just wash it. You don't need to use any higher level chemical agent. Hydrogen peroxide is pretty safe, but then you need to wash it down and wash it off anyway. I don't know what hydrogen peroxide tastes like, so I don't know if it will disturb the taste of those items or whether it causes anything. I know anything that comes in contact with hydrogen peroxide will undergo heavy oxidation. That's one of its active reactions. So I don't think it's a good idea.
So
Okay.
question I have about gloves. So we deal here at the game store in Magic the Gathering cards.
Mm-hmm.
So we have them in binders.
Mm-hmm.
So what we have been requiring, if customers come in and want to look through those binders,
Mm-hmm.
is one, they have to wear a mask,
Mm-hmm.
and two, we provide them with a sealed pair of vinyl gloves
Mm-hmm.
that they put on.
Yep.
They can go through the binders.
Yep. They
can return the binders to us. We wipe down the covers of the binders, and then they can throw out their
gloves.
Yeah. And I think that, when they come into the store, the way the layout works, it just happens to work. When they walk into the store, we have the front door propped open. They have to walk past the bathroom.
Mm-hmm.
Anyway, so we have one of the bathroom doors propped open and a hand washing station set up at the sink there.
Mm-hmm.
But that doesn't mean they're not going to come down the hall and cough into their hand and whatever, and then handle all of these cards that 20 other people are going to do.
That's fine. That's a great idea, because you're containing the glove usage to one location for one task. Okay. And I think we talked about this very early, even before there was guidance, and even before I understood why we don't want the public using gloves, and rather we wanted to promote hand washing, like you just mentioned in your businesses, is that, okay, there's a tremendous amount of waste in the usage of gloves. Okay. Within the healthcare community itself, we're guilty of huge waste, and these are latex vinyl gloves, whatever. They're just, they don't degrade quickly, and there's just a massive amount of trash that's produced. So that's one good reason. The second good reason is cross-contamination. But when you're using it for a specific singular task in a specific location and they're discarded, then you can advocate for that without issue. Early on, I had said, if you're going grocery shopping and you have a germophobia, you have a very high degree of anxiety about touching things that other people have touched in the middle of a pandemic as well, then what you can do is when you are masking before you go into the store, you can put on a pair of gloves. You can go do your shopping, one location, one task. You leave the grocery store. As soon as you leave, you deglove, you throw the gloves in the trash, not in the parking lot, not in the shopping cart, not on the ground. You throw it in the trash, okay? Then that is an acceptable and responsible use of the gloves, okay? But if you put them on at home and decide, well, I'm gonna go to 6 places around town and then come home and take them off, which some people are doing, now you understand why I don't want people using gloves, okay? But yeah, specific task, single location, yeah.
You spurred a quick question for me. It's basically a meme check. We should make a slide for meme check,
Yes.
right?
Yes.
At one point there was a shortage of PPE,
Yes.
and I saw someone claiming that a president who used to be a businessman kind of forced the issue of healthcare workers have to sterilize their PPE in order to use them. And he actually stumbled upon a new way of conserving and not having healthcare professionals throw away all of this PPE. So can you talk about that? Can you sterilize PPE? Is that the preferred?
No, it can be done, but it's not the preferred method. No, absolutely.
Okay. All right.
So, I mean, if you're in a shortage circumstance and this disease had begun to overwhelm all of our health systems across the country, we would have been put into a circumstance where we would have to do that, but it is not ideal. If you have adequate PPE, then there's no point in trying to ration it and then try to clean it, because those processes then introduce even more steps, and each step is then therefore fallible. And so no.
I mean, you have to have personnel and staff to take
Yes.
care of that. You have to have equipment.
Yep. So the more
Okay.
steps you put in place to deal with, sanitizing things, at each step there could be a failure, right? And
Okay.
and then if you have 10,000 masks come through a point of failure, then those 10,000 masks are going to put 10,000 people at risk, right? So you want it, NIOSH qualified or certified, fresh. Use it, get rid of it. In those events, we want to innovate towards things that are more biodegradable or recyclable, right? So recyclable meaning it actually is completely cut apart down to its constituent molecules and then reassembled back into something useful, not take a mask and put it in an autoclave and hope that, by the 10th time it's still effective. That's not ideal. Okay.
Okay.
Okay, so there were questions on vaccines. I'm only going to focus on two right now. These are the two that are at the head of the pack. There are over 127 vaccines that are in a clinical trial right now. The two that are the leaders are the one being developed by Moderna, which was announced as part of Project Warp Speed here in the United States. It is a RNA vaccine, and what that means I'll show you on the next slide, but basically it is, you take RNA that encodes for a spike protein. The spike protein you've all seen is the little red crown around the COVID, around SARS-CoV-2. That is what we call the antigen that is of interest to the immune system. We need to teach your immune system how to deal with that. And so we start with its precursor, which is RNA. We inject the RNA into your body, and I'll show you on the next slide or so how that works. And what happens is the body takes it up, it produces the spike protein natively, and then the immune system recognizes that as a non-self protein and then starts an immune response. So it kicks in the adaptive immune response, okay? So I have a lot of trepidation around this methodology. I discussed that in a couple of earlier town halls, but we'll see how it goes. There are others that believe that this may be the fastest way to get a vaccine to market. How effective that vaccine will be, we'll have to see. The Oxford group in the UK is taking a different approach, which is they're taking an adenovirus, right, different category of virus, same Baltimore classification, and they are giving it the RNA to produce the spike protein. So basically, they're making a virus look like the CoV-2 virus, okay, but it's not CoV-2. So it doesn't have all of the infectivity and life cycle of COVID. It just looks like COVID to your immune system. So it's like providing a decoy in adequate quantities so that your immune system thinks it's being infected by COVID, and then it develops an immune response to COVID so that if it comes across with COVID in the future, it knows what to do with it. Got it? Non-replicating viral vector. John has helpfully put it, the two methods in green and blue. RNA and then adenovirus. So Oxford and Moderna are the two leaders right now. Okay, and maybe in a couple of weeks, when we have to decide which virus to choose, which vaccine to choose, we'll have Dr. Nuthi from India, who's an expert on vaccines, come and talk to us about why we should take one vaccine over the other. Okay, so this is the process for the Oxford group. They take the chimpanzee adenovirus, they modify it. Through gene manipulation to make sure that it cannot produce disease. Even if it did, it would cause a cold, because that's what adenoviruses do. But it doesn't even do that. So they then re-engineer it to produce that red spike you see. And then what it will do is it will look like the COVID virus, SARS-CoV-2, to the body, but it's not really. It just looks like it because it's wearing its hat. And then the body starts producing antibodies to it. And then, so if you do get infected by SARS-CoV-2, your body has already seen a trial run or a dummy of it, and so it knows how to handle that and produce antibodies to clear it. Okay, and the next one is the Moderna approach. And what the Moderna approach is a little bit, the diagram is complicated, but the process is actually somewhat simpler. So they take the SARS-CoV virus, they open it up, they take out the mRNA, the RNA. They look for the part of the RNA that codes for, or is the blueprint for, that spike protein, okay? And then they just take that and purify it and amplify it so they have a big quantity of it, big meaning it fits in a syringe. And they inject it into the muscle. Now, all muscle, human muscle, has something called satellite cells. They are the adult version of stem cells. The adult version of stem cells, why are they necessary in your muscle tissue? It's because that your muscle has a very high cell turnover. It's constantly repairing itself. It's constantly restoring muscle mass. It reacts to strain. So if Karen decides to go to the gym and, 4 weeks from now, her biceps are about an inch thicker because, they've been stressed, and the satellite cells kick in and they start producing more striated muscle. Okay, that's how the body builds muscle. So we take advantage of these living stem cells by providing high concentration of RNA. These satellite cells uptake it, and because they're so metabolically active, they produce the viral proteins. You can see that the ribosome kicks in and they start to produce the viral antigens in blue on that first box there. And then if all of this happens within the cell, then it stimulates the major histocompatibility to tell T cells, hey, this is a new protein, it doesn't belong to us. The T cells then tell the B cells, and then you have your immune response. This is the adaptive immunity. Pretty cool. Hasn't been very effective in other diseases. This is the way this was my senior thesis on HIV at University of Pennsylvania. But we don't have a nucleic acid vaccine for HIV either. So we'll see how this goes.
So if you want to impress your friends on this topic, the biological abbreviation mRNA is obviously messenger RNA, right? So the NASDAQ stock symbol for Moderna is also mRNA.
Oh, okay, cool.
So just in case you wondered, these are the things that I keep in my brain for some reason.
That could be a pickup line.
Guess who's not buying mRNA stock? This guy.
Now, I did hear you slip in earlier. I heard you say 2 years, and I've heard someone else say this fall.
Yes.
So I caught a little discrepancy, and I just wanted a quick thank you for inventing an alternate world where I go to the gym.
Yeah. Yeah. Okay. All right. So those are the vaccines. Any questions on vaccines?
I got one.
Yeah.
Realistically, how long it takes other vaccines to come to the forefront, is 2 years realistic?
Okay, so great question. I think that so what I've been reading about is that there are teams with very, very advanced states of vaccine development. One at University of Pittsburgh Medical Center, UPMC. One at Baylor. Okay, and these are for SARS-CoV-1, right? So they can modify that work, having already gone through the animal models and all that stuff. They can just reproduce their experiments with and the development with the new virus, and probably get a viable full antigenic picture vaccine out by September, October of 2021. Okay, that's the fastest traditional vaccine development methodology, because they've done all the work. They have 7 years of work behind them, right? They've done all that, and so they have. If they wanted to launch a SARS-1 vaccine, they could do it in 3 months. If they need to do it for SARS-CoV-2, what pandemic is based on right now, it would take about 18 months, but they already have a head start. So I would say by the end of 2021, those two vaccines could come to market and be viable and effective. Okay, but then you need to do what we call phase 4 clinical trials, which is we're going to give this to 15,000 patients, and then we're going to follow them for 4 months or 6 months, and we're going to have to see if there's side effects, if there's anaphylactic response, if there's autoimmune disorder caused by this, if all of this stuff, right? What does it do in various age groups? How young a patient can you give this to? How old a patient can you give this to? That takes a lot of time too. So until that data is collected, that's 2 years, right? So that's 18 months plus 6 months, 2 years. So yes, it would be a 2-year time frame from June 1, right, to make sure that we have a safe, effective vaccine. And
so in other words, fall of 2020 is not a remote possibility given everyone that you've talked to.
It is if you just want to inject people with RNA. No problem. We can get you a purified saline solution with RNA and stabilizers and put it in your arm and then cross our fingers. Is it safe and effective? I don't know. We'll see. But you know, I'm letting John go first. Terry and John are going first, not me, with the Moderna vaccine.
I'm sticking with bleach and ultraviolet light. And got the bleach in my vape. I'm healthy as a horse.
I wish not to become one of the 20 seconds at the end of a pharmaceutical commercial.
I mean, come on. You hear what I'm saying, right? Like, I just broke down why you need phase 4 clinical trials. You need age group discrepancies. You need to study interactions. You need to study autoimmune response. There's so many things that you need, and you need a minimum of 10,000 patients to do it. Okay, you were telling me June, July, and August, Moderna's going to have all that stuff done. Okay, stash that with all the other lies that have come out of this administration. Sorry. Anyway, next. So, next slide. Okay, so here's the crazy complicated stuff that we figured out now about what this disease does. And, you know, proud to say that we brought this forward at least 4 or 5 weeks ago in one of our town halls, where, you know, started to realize that people were seeing that this wasn't just a pneumonia, this wasn't just a flu-like illness, that people were dying because of microclots in very dangerous and significant places like their liver, their kidneys, their lungs, their heart, and even strokes were occurring. So strokes were killing people. So they were getting clots in your brain. And these were happening to young people, 34, 45, 52-year-old patients were seeing, you know, disseminated intravascular coagulation, lots of microclots. And even in those patients that didn't die from it, their recovery was extremely painful and elongated by the fact that they had all these little clots all over their body. Autopsies showed that there was significant pulmonary embolism and infarcts in the heart and lungs. So we realized that this is part that the virus was stimulating part of the coagulation cascade, and that we needed to figure out which of the drugs that we use to prevent clotting, which we, in public we call them blood thinners, are going to be the most effective. So there was talk about whether aspirin could be used as a effective prophylaxis against clotting in COVID, and was realized that aspirin works in a different way and not necessarily on the coagulation cascade. And then doctors started to use the old and trusted methods to prevent clotting in patients in the inpatient setting, and that is heparin. So specifically, low molecular weight heparin began to show extreme promise in preventing the clots that ended up being deadly for these patients. So that's what has primarily been used as a successful anticoagulant. And others are being, investigated, but right now that's the one that has formed up to be our primary tool for anticoagulation. The second one is a whole host of anti-inflammatory drugs. So we have nifamostat, we have famotidine, we have IL-6 inhibitors like tocilizumab, cetuximab, which is used in cancer patients. So we have an arsenal of monoclonal antibodies, which you'll see as the central stack of Y-shaped objects here. These can all be used successfully right now, and they're being tested to see which one is the most effective to stop the cytokine storm, that inflammatory response that overwhelms the body and shuts it down. It's an autoimmune response, and that so we're testing which ones are most effective. But IL-6 inhibitors specifically are the ones that are being seen as the most effective right now, with other ones following close behind, like famotidine, nifamostat, tocilizumab. Now, antivirals. Antivirals are a big class of drugs, and we have an arsenal from HIV research that we're testing. Right now, the one that is most promising is one called leronlimab, and the leronlimab paper I have here, as well as the tocilizumab paper. So yeah, so we're seeing, but again, guys, this is the first paper, okay? We need like 5, 10, 12 sentinel papers with large groups of, large, well-powered studies. And a power is something we call just the number of patients involved, or the N. So in general, we look at a study that has more than 10,000 patients as being extremely well-powered. Over 100,000 patients is, magnificent. Anything under 1,000 patients could be indicative. But then when you have studies that are in the hundreds of patients or less than 100 patients, it actually might just be anecdotal, right? So it worked on, like, we had this problem with hydroxychloroquine. Oh, I said the H word. Where, 36 patients underwent treatment, and John's looking at me. And then all of a sudden it comes across the news wires, and not all the information, not all the data, and then you have problems. So
you're not allowed to say that word. You told me that you were never saying that word again on these things.
I know, but I had to. You know why? Because 2 of the papers were retracted.
Yeah, the Lancet backed off of.
Yeah,
I read that.
Yeah, they backed off of the negative reporting on the effectiveness of hydroxychloroquine. But I want to touch on that. The reason is that the data is being held by a private company called Surgisphere. Surgisphere put all the data into a repository, and when they were asked to release the data for further peer review, they refused. So unless they were allowed to further peer review the data, the Lancet said, we can't accept this as a standard of publication. So the findings might be correct, the patient reported data might be correct, The fact that hydroxychloroquine is not effective may be correct, but nobody can, it now belongs in the journal of your reproducible results. So there you go.
So the hope is that if we can get a therapy, that we can cut the death rate, and that will get us to the final finish line of a vaccine.
Yes.
and save people in the meantime. And if you are going to get this, it's better to get this in a few months when we
Yes.
have more options.
Correct.
I do have a question, though, because when I was eavesdropping on your conversation with all of your doctors, and I really only understood 10% of what you all were saying. But in this eavesdropping, I thought that I heard one of the doctors indicating that positioning seemed to be
Yes.
more successful than going on a ventilator.
Yes, correct.
I found that fascinating. So do they turn people like over and like to the
Yep.
side, or?
Prone position and angled up. So basically the majority of the mass of your lungs is not in the front of your chest, it's in the back. So when you're laying like this, you're allowing the majority of your lungs to fill up with fluid. When you lay on your stomach, the majority of your lungs then rises up out of that sogginess, right, and is allowed to, it can ventilate. So proning the patients early is resulting in better outcomes. Allowing the patients to be hypoxemic up to about 80% on room air without ventilating them mechanically is proving to be beneficial, because venting a patient is invasive, it's damaging, and it comes with a host of risks, including ventilator-associated pneumonia, damage to the pleura and parenchyma of the lungs, as well as those capillaries that are fragile. So it's a intervention of last resort. Unfortunately, as soon as these patients came in crashing and their blood saturation was below 90, doctors like, vent them, get to the ICU and vent them, because that's how we would normally deal with patients in acute respiratory distress. But we've realized that can do more damage to some of these acute patients, and so we keep them out of that risky situation as long as possible. And people are arguing, well, if you keep them out of that situation, it might be too late to put them on a ventilator. It's actually quite the opposite. The longer we keep them off the ventilator, the better the outcomes. That's
fascinating to me.
Data is showing. Yep. Okay, and the last part of our discussion is so this is where the webinar format is not great, and I don't think we have successfully used the Q&A at all. So John, I think we might have to go back to our previous format where we can see everybody's pretty face. But anyway, so again, we'll cover this because it's important to cover. It's week 12. What have we learned? Keeping distance is very useful. The World Health Organization says 1 meter. I say 3. So between 6 and 9 feet is a good distance. If you're standing in line for something, like, for example, I had to go to the UPS store a number of times, and they have little pieces of tape outside, and they're giving us a good 4 to 6 feet away from each other, and that's great. 4 to 6 feet away from each other if you're standing in line, outstanding. Even better if you're standing in line 4 to 6 feet away and you're wearing a mask, okay? Wash hands thoroughly and or use hand sanitizer when you leave a location of high human traffic. So if you go into your whatever store and you come out and before you put your hands on your steering wheel or whatever, better to realize that, okay, I just went into a contaminated environment. Let me just sanitize quickly, or let me wash my hands quickly, and then go back into what you would consider a hygienic environment, which would be your car or your home, okay? As soon as you do get home and you've unloaded your groceries, another great time to wash your hands. Although the virus only lasts hours on surfaces, it could be in that short period of time that you do have it on your hands and you touch your face or nose or eyes, rub your eyes, And again, you're risking infection. So the best thing to do is anytime you come back to your home, preserve your home as the hygienic environment, or your car as a semi-hygienic environment, wash or sanitize your hands, okay? Avoiding handshakes and contact. I don't like this, but if it's with people you don't know, you best not do that. If it's with people that you know, I don't want us to break down human bonds, like we talked about last week with Dr. Racimus. You know, it has to be said, I guess, because, you know, we look at what people know and what people don't know, and it's startling. So you can hug and kiss your kids. You can hug and kiss your family and friends that have not been sick in the last 6 weeks. But you should not be hugging and kissing randos. Okay. Sneezing into the crook of your arm using a tissue. You know, obviously be aware that, you know, big hearty sneezes in public are not going to be very welcomed. Stay at home if you do feel sick. If you really do start to feel sick, please call your healthcare provider immediately. Do not delay seeking treatment. Do not delay seeking testing. Okay. Obviously, from what we saw earlier in the presentation, the elderly are at very, very high risk. Everyone over the age of 75 has shown, who has been exposed and developed the disease, has been shown to have a very high mortality rate. So when you see an elderly person in public, be especially cautious and careful around them. You don't know if you're carrying or not. And obviously, we don't want them to get sick. Next. Washing hands is critical here. So again, no gloves, no gloves, no gloves. Good hand hygiene, good hand hygiene, good hand hygiene. Next. We already did this one. Okay. And please go see your doctor if you're feeling ill. Get tested if you're feeling ill. Testing is getting to be or is already ubiquitous and readily available, not like it was a month or 2 ago. If you do feel a dry cough, runny nose, sore throat, or fever especially, as well as any GI symptoms, it should mean that it is a valid time to go and get tested and assessed. Okay? And I think that's it, right?
This is the last one here.
Yeah, okay. Did I have the new normal one about travel, healthcare, camp, work, and then stuff like that? Anybody have questions about going back to those activities? There we go. Yeah.
Let's just say I wanted to go to the gym to lose my COVID-20.
I've got a COVID-20 too. Absolutely.
How risky is the gym?
Risky.
Yeah, I knew you were going to say that.
Yeah.
So I have a legit reason not to go to the gym. Is that what your official?
I'm not going to officially say. I'm going to say that there's other venues in which you may pursue physical activity that is safer than a gym. You know, I wish I could say that they are safe, and I'm sure that the gym owners are doing their best to sanitize, and that's going to be something that's going to be required of them to be more diligent. But imagine you've got somebody at a very high respiratory rate on a treadmill for 20, 30 minutes. What are you going to do? Ask them to wear a mask? And even then, they're going to saturate that mask within a few minutes. So it is not, and even if you're doing weights or Nautilus or whatever, you're in a closed environment. In the summertime, it's going to be air conditioned. We know that there's threat of recycling droplets through air conditioning and HVAC. It's a difficult environment to keep safe. So gym owners, if you got a parking lot, move that crap outside. keep the equipment, 12 feet away from each other, and promote, get a tent or something, or, make sure there's plenty of cross airflow or whatever. Innovate. But, getting 20 or 30 people into the same space they used to use in January at this stage, I wouldn't recommend it.
So here's a question. How about limited access public pools?
I think we talked a little bit about this a couple of weeks ago. Summertime is beach and pool weather. And if you're at the beach, you're in an outdoor environment. The water is full of, has a very high salt content. It's generally breezy. It's generally sunny, and that's an unfavorable environment for a virus. Especially if you're, 6 to 12 feet away from anyone else that you don't know. If you're with your family group and everybody's has been well for the last 6 weeks, and there's, you're with people, and everybody's either tested healthy or has been healthy, you can go sit on a beach for a long period of time and enjoy yourself. But then if one of you gets up to go to the hot dog stand and stands in line for 20 minutes, 2 feet away from, 3 dozen people, that's when you're putting yourself at risk. And the same holds true for the pool. So the pool water itself is, chlorinated, brominated. It's not a friendly environment for the virus. Somebody sneezes into the water or whatever, that virus dies very quickly in that water, as it would in salt water, seawater. But if you're sitting at the edge of the pool and somebody sneezes, or there's expectorant, or there's running around and activity, and it's overcrowded, then you're again at risk. So you need to, if you show up at Francis Slocum and there's 50 people all hanging their feet in the pool with no social distancing and no one wearing a mask, I wouldn't go in there, right? If you're, now there's a question about hotels, so let's use that as, if you're at a hotel pool and there's 3 people there and they're all sitting 10, 15 feet apart from each other, then you should be fine. You'll be fine. Okay.
Carol, you have to tell us where you want to go. We want to. I want to live through you. Where are you going?
I want to go anywhere. I'm supposed to be in Norway right now. It's really pissing me off. Yeah, no, I'm just like, yeah, we were kind of wondering, what the risk factor was in hotels.
Yeah, so I would say that these guys, especially at Premier Hotels, are taking this extremely seriously. Michael Null, who has been with us almost every week now, works for a large resort group in Utah. And I think that, again, in the initial period, they did not get guidance from either their industry or from the government. But more recently, they've self-organized and have started taking things from World Health Organization and other international tourism and hospitality authorities. And so Marriott Group, Hilton, and others, not that I'm pitching for them, but the big groups have now standardized, and they are insisting, because we don't know if they're going to be liable for lawsuits. If you can say, and look, yeah, I stayed at your hotel and I got sick, and then some lawyer turns around and tries to sue the whole group, right? So they're going to be trying to be extra careful. And so sanitizing their hotel rooms and et cetera, especially in this initial period, they're going to be very diligent. I wouldn't feel at risk staying in a hotel room.
Okay, thanks, Sanjay.
Yep, absolutely.
If I could say, if you go to a hotel and you do get sick, the law firm of Yudoshi Month will take your case.
Sanjay, what about a marijuana store?
You mean going in to shop there? Yeah, it's no problem. Absolutely, it's like any other store. Are they closed? Are they essential?
That was for you, Cynthia.
Are they essential? Are they considered medicinally?
I thought that they were limiting access to them.
I think there's, in different states, they have different classifications for that.
Yeah.
I don't know what I know we have medicinal dispensary. Yeah, tell me, John.
Yeah, the only thing we have in Pennsylvania that is legal is the medical dispensary. So they're considered medically essential.
Good.
Same thing with the liquor stores.
Yeah.
I heard that
about
they
that.
are. I heard through a friend of a friend that they were very crowded in Illinois.
Are they? Yeah.
Yeah. So I guess it depends on how busy they are. But that's through a friend of a friend, because I live in Wisconsin where it's not legal. So.
Oh, I didn't know that.
Yeah.
Oh.
So that's how I heard.
So you have to go across the border or something?
Oh no, I would never do that.
Okay. We are live on Facebook. It's not like I'm not in enough trouble already there.
I would never tell people to go across the line.
No.
All right. Well, we are at our time.
Yeah.
We always do this. We always run out of time on the live stream video and the recording video here. So we will end this for here, and then we'll all hang out and have off-the-record conversations.
Excellent.
But I want to thank everyone for joining us again for our 12th week of doing this. It's always lots of fun. So we'll be back next week, and we will teach Sanjay how to run the webinar software properly by then.
Oh.
Okay, maybe we won't. All right.
Okay.
Thanks, everybody. Have a good night.
Thank you.